Hello everyone. Welcome to another Rafael Medina virtual morning report. I'm Youssef. I'm a resident in Atlanta. I'm very excited for our infectious disease session today. We have Dr. Spottiswoode with us today. Would you mind introducing yourself and tell us why trainees should go into infectious disease?
Hi, thanks so much, Yusuf. So yeah, my name is Natasha Spottiswoode, but please call me Natasha because Spottiswoode is way too long. And in terms of why people should go into ID, I have a couple reasons. First, you get to be a detective. You get to solve all the weird, mysterious problems that people have. Secondly, you get to be an advocate. You get to work for people who have oftentimes been marginalized or have not necessarily been well treated by society and who are at higher risk of infections. So you get to be an advocate, you get to be a mystery solver. And thirdly, you kind of get to engage with issues that change the world. We are all becoming doctors or healthcare providers in an age of outbreaks, in an age of plagues. And so that makes us very relevant in the world that we live in.
Tasha, thank you for this inspiring message. And I want to introduce Navila Sharif. Navila was my intern last year, and I just wanted to tell a small story. One of our patients, unfortunately, we wanted to do a lumbar puncture to rule out like a cerebral infection, and Navila was the intern taking care of that patient. And I remember multiple teams take care of this patient, including infectious disease, neurology, and when they were trying to do the consent for the lumbar puncture, the family would only accept the lumbar puncture if Navila was approves it and if she accepts it. And Navila, would you mind introducing yourself and tell us what is something you're grateful for?
Sure. Thanks, Yusuf. I'm Nabila. I'm a second year medicine resident at Emory. And like Yusuf said, he was my amazing upper level last year, right around this time, which is very odd because somehow I'm doing that now. And so thank you for the sweet story. In terms of what I'm grateful for, so I will do like one kind of work related and maybe one not so much. I'm in the MICU right now, and it's my first time being in a situation where we don't have like fellows or attendings overnight. There's just one resident, like myself and whoever's on call. And it's been a really cool experience to get to watch yourself transform a little bit. And we've seen some really cool cases. So I think I'm just always grateful to have the privilege to do something like that. And then kind of on a lighter note, I am very happy that it's fall. Just coming home today. First of all, I got out today, which was exciting. And second, just walking into this like crisp air, I was like already so happy. So those are the things I'm most grateful for today.
Yeah, that is amazing. Navila, if you're ready and if the person doing Skyping today wants to share the whiteboard, feel free. Uh, Give me a few seconds just to give them the access.
One second, please. I'm having some technical difficulties.
No worries, Mario. Okay, thank you so much. So I think Navila, whenever you're ready, we should be good.
Okay, awesome. Let's get started. So for today's case, we have a 37-year-old female with a past medical history of sphincter of OD dysfunction, short gut syndrome, chronic pancreatitis, gastroparesis with multiple prior G tubes, as well as malnutrition with TPN dependence, who presented with fevers, chills, and malaise for the past 4 days.
And Navila, if you can just give us a little bit more information, and then we can go over some of the
Yeah.
questions.
Will do. So this patient noted that she kind of acutely over the past few days started having feverish chills, night sweats, and just being fatigued overall. Over the past day, she also noted worsening nausea, vomiting, and a non-radiating deep epigastric pain. She has abdominal pain at baseline and is opioid dependent, but this had acutely worsened. She denied any headache, neck stiffness, cough, shortness of breath, chest pain, rashes, joint pain, or dysuria or diarrhea. She had no recent sick contacts, no recent travel. And then in terms of, well, we can kind of wait a little bit for past medical history.
Yeah, thank you, Nabila. Natasha, jumping to you, I just had, how do you think about fever and abdominal pain? I know it seems that it's only been for 4 days. Does that change your framing for like the etiology and how you would approach this patient?
Yeah, so in terms of framing this patient, I'd like to call, first of all, thanks for the great start and the great presentation. So I'd like to start naming some of the syndromes that I'm worried about. So first of all, your history of fevers, chills, night sweats, it means she's inflamed. If we were to get a CRP, we shouldn't, because we won't need it, but it would certainly be elevated. So, and then the causes of inflammation, in this case, everything is pointing to infection. She doesn't have a known history of hematological abnormalities. She doesn't have a known history of rheumatic disease. What she does have, though, is several excellent reasons, unfortunately, to have an infection. And I'd break down the reasons why she has an infection into two buckets. One of them is that she has risk factors for an abdominal infection. She has abnormal GI anatomy. She has prior episodes of pancreatitis. In fact, I would also clinically say that she is having pancreatitis. And that puts her at risk from things that come from the gut. So we're dealing with our gram negatives. We're dealing with enterococcus as a gram positive. We're dealing with candida. Her second bucket of risk factors is that she's on TPN. So TPN, or total parenteral nutrition, is basically a way of giving people nutrients that goes through a catheter in the skin. And although it is absolutely necessary for some people, it causes significant risks, both because, one, it is a break in the skin. So there's a place for skin flora, so your gram-positive, your yeast, to get into the bloodstream. And also it's a very, very rich nutritional environment for things like yeast. So I'm putting her buckets of risk into skin bugs and abdominal bugs.
Yeah, love to hear it. Nabila, back to you.
Awesome. That was already so helpful in thinking about this. So just a little bit more history. This patient has been on TPN for about 2 years, and she has a right chest Hickman catheter that was placed 8 months ago prior to presentation. She does have prior infection history, which is significant for Klebsiella pneumoniae bacteremia and Candida glabrata fungemia about 1.5 years ago. And then she has also had Bacillus bacteremia complicated by septic emboli a few months after that. But all of those were a little over 1 year ago.
And I think we can go through the meds, family history, social
Okay.
history, all the way before the vitals.
Perfect. So she doesn't have a lot of home meds. They are all pain medications for this kind of chronic abdominal pain and all the surgeries she's had. So she's on a fentanyl patch at 100 mcgs an hour. She's on oxycodone 10 milligrams, and then Dilaudid 4 milligrams TID PRN. She also takes antiemetics, kind of PRN, usually Zofran. For past surgical history, she's had a cholecystectomy, she's had a bowel resection, G-tube and J-tube placements, which are not currently in, and then multiple CVC placements currently with the right Hickman. In terms of family history, no significant family history was noted. For social history, the patient is from Georgia. She lives at home with her husband and 2 kids, no pets at home, no recent travel or hiking. I think that's all I have for that section.
Yeah, thank you. I think Natasha, my question for you is, does the history of infections, Klebsiella, Candida, Bacillus, bacilli, make you think of something like chronic, or do you think this tells you more about the patient's risk? And my second question is, infectious disease doctors are known for their physical exam. How would you approach like physical exam in this patient?
Yeah, so I mean, her history of bacteremias and fungemias makes me worried about a couple of things. Firstly, if you've had bacteremia or fungemia with a particular organism and you think someone has another infection, I use that to guide the way I would empirically cover them while I'm figuring out what's going on. It also adds a third, I think we're sort of circling around a particular diagnosis where we think she most likely has a bacteremia. I suspect very strongly that her blood cultures are going to be positive, given that we have two possible sources of an infection that could go in her blood, a history of bloodstream infections, and also a clinical picture very consistent with a bacteremia or a fungemia. In addition, you've brought forth something else, which is a history of endocarditis. You mentioned, or at least you mentioned, metastatic Bacteroides infection, which to me suggests endocarditis. And it is definitely the case that having prior endocarditis puts you at risk for future endocarditis. So going into your question about exams, so as I examine her, I think I'm going to focus on a couple of different systems. I'm going to focus a lot on her heart and listen super carefully, although I will say my ears are not the best. But also I'm going to do a really detailed exam for signs and symptoms of endocarditis. So looking at the hands for Osler's and Janeways, looking sort of a full skin exam as much as I can do. And then I'm also going to look at her abdomen. You're giving me a story which makes me quite worried about acute on chronic pancreatitis, and so I'm focusing on her epigastric region. I also would like to get a little bit more of a sense of her anatomy and make sure that there isn't sort of concern for an intra-abdominal abscess. So I'm focusing on her abdomen and signs and symptoms of endocarditis, I think.
Thank you so much. Nabila, back to you for the vitals and the exam.
Awesome. So starting with vitals, her temperature on arrival was 39.6, heart rate of 127, BP 108/64, respiratory rate was between like 18 and 20, and she was satting 95% on room air. Going into the exam, for general, the patient was toxic appearing with visible shakes and rigors. For HENT, there was nothing too significant. Her pupils were equal, round and reactive, extraocular movements were intact, no scleral icterus. She did have dry mucous membranes. For cardiovascular, like you, I also am not a great listener, but we did not hear any murmurs from the rest of the team as well. For respiratory, she had normal work of breathing on room air. She did have crackles at the bilateral lung bases. For GI, her abdomen was soft and non-distended. She had tenderness over both the right upper quadrant and the epigastric region with no guarding or rebound tenderness. For MSK, she had non-pitting ankle edema, but full range of motion. On skin exam, she had a right chest Hickman with no surrounding erythema, warmth, tenderness, or discharge. Neuro exam was normal with no lateralizing deficits, and she was learn oriented ×4, and psych exam was also normal, and no signs of endocarditis on skin exam.
Thank you. Natasha, given this exam, what are your thoughts, first of all, and second of all, what would you want to do next in terms of blood work and imaging, just like as an initial screening?
Yeah, I mean, this is not a reassuring exam. These are not great vitals. You know, there's a saying that the scariest arrhythmia is sinus tachycardia. She's certainly responding to some sort of septic stimulus. Her temperature is high, her heart rate is high, her blood pressure is probably a touch low. And of course, she's described as toxic looking, which is always worrying. So next steps that I'm going to take with this exam. Oh, and I also want to highlight that I am surprised by her crackles at the bilateral lung bases, which raise my concern for several things. It would be surprising to me if she had a concomitant pneumonia, because you have not given me any history thereof, but not all that crackles is pneumonia. that raises my concern for septic emboli to the lungs potentially, or potentially fluid overload generally. So what am I going to do? I'm an ID doctor. I want blood cultures. And I would like basic labs as well, although I think that the CBC is going to show an elevated white blood cell count, and the basic metabolic panel may or may not show an AKI. In terms of imaging, I would definitely like to start with a I would definitely like to start with at least a chest X-ray, and then based on the chest X-ray, I would decide whether or not I wanted a chest CT. I right out of the gate actually wanted an abdominal CT, given her abnormal anatomy and the concern for a source. So I would probably start with the chest X-ray, then make a decision on the chest CT, and definitely get an abdominal CT. Do you also want me to talk about empiric treatment?
If you want to do that now or after the initial blood work and imaging, feel free. If you think we can do that now, we can.
Let's do it now, because who knows how long the CT will take. The emergency room might be busy if we're down there. Certainly she's going to deserve empiric treatment. I would use antibacterial. So I always break down empiric treatment into antibacterials, antifungals, antivirals, and other. In this case, you're giving me a fantastic story that deserves actually both empiric antibacterial and antifungal treatment, and it's fairly rare that I reach for empiric antifungals. For antibacterial treatment, I would want something that covers both MRSA, because I would consider her to have significant healthcare exposure and a potential bloodstream infection from a skin source, and then Pseudomonas. Unless she had resistant bacteria that I don't know about, I might choose Vanc Piptazo as my antibacterials. In addition, I would like to start an antifungal. Candida glabrata is one of the nastier candidas, and so I would definitely start mycofungin at this moment.
Yeah, and I don't know if you saw this new paper last week citing that like the vancomycin and the cefepime might not have that much of a benefit in regards to AKI. Did that contribute to your choice of Vanc and Piptazo, or is it to cover anaerobes?
Actually, the reason I would want Piptazo is I think it has. Yes, I would like it. So, sorry, taking a step back, the paper that you're referring to is a great relief for all of us, which is that Vanc and Zosyn together do not cause AKI. I like Zosyn for this because it covers anaerobes, and also because I think of it as having slightly better enterococcus coverage, and enterococcus is a gram-positive that is going to be covered by the Vanc anyway, but AMP-sensitive enterococcus is something we often see from the GI tract. Also, I would like to point out that Candida glabrata has a new name. It's called Nacasiomyces glabratus, which is horrifying, but we can keep calling it Candida glabrata.
The Microbiological Society keeps changing the names. It's so confusing.
It's so confusing, and also no one can say it, but it's part of the world that we're going to have to live with, I think.
Yeah, thank you so much for that teaching. Nabila, back to you.
Okay, so going into labs, the CBC was significant for a white count of 2.9, 84% neutrophils, 10% lymphocytes, a hemoglobin of 5, and platelets of 60. So overall pancytopenia. BNP was not very significant. Electrolytes were all within normal limits, and creatinine was 0.45, which was at baseline. AST, ALT, and ALP were also all within normal limits. She had an elevated an elevated procalcitonin at 1.4, and a lactic acid that was normal at 1.4 as well. She had an elevated LDH at 413, a D-dimer that was elevated at 27,948, INR of 1.6, and a normal fibrinogen. We did get blood cultures that I will talk about soon. And we started empiric antibiotics with Vanc, cefepime, Flagyl, and we called ID right away to get the permission for the MICA. And then going into imaging, so you initially wanted the chest X-ray, which showed patchy airspace opacity in the right upper lobe that was concerning for pneumonia. The next imaging that we got was a right upper quadrant ultrasound, and that showed no biliary obstruction, but it did show hepatosplenomegaly. CT abdomen had no acute findings except for the mild splenomegaly. And then the CT chest showed multifocal ground glass opacities and nodular consolidative opacities, worse in the left lower lobe and right middle lobe that was suspected to be multifocal pneumonia per the read.
Yeah, I think this caught me off guard a little bit as well because the patient is on room air and with no oxygen requirements. It was found to have multifocal opacities on imaging. Natasha, how do these like labs and imaging change your how you're framing this patient and what organisms do you think of?
Yeah, so two big curveballs here. Number one is the chest imaging. So I'm going to take a second and say she has very abnormal chest imaging. Does she have pneumonia? Pneumonia is actually kind of a hard diagnosis for how often we invoke it. And for pneumonia, you have to have sort of three components. One, you have to have imaging that's consistent with pneumonia. Two, you have to have signs and symptoms consistent with pneumonia. And three, you sort of have to have labs consistent with the pneumonia. And in her case, I guess she does have the crackles, but you've given me a totally normal respiratory rate. I guess a saturation of 95% is actually not normal for a healthy person. But you're certainly not giving me a great story for pneumonia, which makes me think that this is either not atypical bacterial pneumonia or not pneumonia. So taking a step back from that, the other thing that is really grabbing my attention here is her really impressive CBC. I did not expect her to have a hemoglobin of 5 and a platelets of 60,000. And that sort of puts two big possibilities into my mind. One of them is, has she had regular CBCs? What is her hemoglobin baseline? You mentioned that she has nutritional deficiencies. You'd have to have a really bad nutritional deficiency to get this low, but it is not unheard of. The other possibility is her bone marrow acutely suppressed as a result of some insult, whether it's an infection or a secondary process to an infection, such as DIC. You're not giving me a good story for DIC, which is great. Her INR is elevated, but not terribly. Her fibrinogen is normal. Her LDH is high. But I have never seen DIC quite get someone down from a normal hemoglobin to a hemoglobin of 5. So the other possibility in my mind is she bleeding and where? So taking a step back, there's a couple things about this that are surprising to me and make me want to ask a couple of questions about what prior immunosuppression, if any, she's received. You said that she had received only really opiates. Had she been given steroids for any reason in the last few months?
No, no history of immunosuppression really in any way. Yeah, no recent steroids.
Yeah, interesting.
Her hemoglobin at baseline, she does have anemia, but baseline's like around 9, I believe. And then the rest of the CBC was normal as of a few weeks ago.
Fascinating. Well, there's a couple different possibilities here. So just to name some of them, I am still very worried about endocarditis. I still think that is very possible. And although these nodular consolidative opacities are not typical for it, I'm still getting those blood cultures. I'm still starting those meds that we talked about. I'm still worried about that. GGOs and nodular consolidative opacities make me think about not bacteria in particular, although imaging is neither sensitive nor specific. So then I'm thinking about the buckets of things that can affect the lung that are not bacteria. In this day and age, COVID, always, as well as other respiratory circulating viruses. You want to always test for flu because you can treat it quite quickly. So I'm sending a flu, a COVID, and if she gives me a history for it, a respiratory viral panel. In terms of other possibilities, fungal infections can certainly do this. I'm thinking about endemic fungi. I'm thinking about, in particular, endemic fungi can also infiltrate the bone marrow. So that might be an interesting way of linking those two. So I'm thinking about our histo, I'm thinking about our blasto. Where I live in California, we are one of the world capitals for coccidiomycoses, which I just call cocci. So that's also on my differential. So I'm thinking about those as well and asking her a few more questions. And then the last thing, sorry, is PJP. She is not the typical person I would think about having PJP. You gave me the LDH, I think, as a way to look at that. but I would be very surprised if she had PJP, because although she is immunocompromised, I think about the risk factors for PJP being typically decompensated HIV, secondary steroids, and although it is more subtle and harder to diagnose in people who don't have HIV, she really does not have the risk factors for it.
Yeah, and feel free to ask Nabila the questions directly if there's anything that can help you if you prefer, if you want.
Yeah. So she's in Alabama, right near Georgia.
Sorry, she's in Georgia.
She's in Georgia.
Yeah.
And you said no hiking and no sort of travel outside at all, right? Okay.
No hiking, no rivers, lakes.
Interesting. Well, the way I would put this together is that she has, and then sorry, you said she has 2 kids. How old are they?
She does have 2 young kids. I believe they were like 4 and 6, something like that. One did have a recent URI.
Got it. 4 and 6 is a fantastic age for spreading respiratory viruses.
Mhm.
So just putting that out there. And so the other thing that I'm thinking about is whether or not she has parvovirus, which might explain the pancytopenia, but would be very puzzling to me about the rest of her abnormalities. Specifically, it doesn't explain the right upper quadrant. It doesn't explain the GGOs. I think we're looking at if there is one unifying diagnosis here, and there's always the possibility that we're dealing with more than one, we're looking for something that's affecting the bone marrow, the chest, hepatosplenomegaly, so a disseminated disease. And for that, I think about endocarditis. I think about a fungal infection. I have trouble attributing this all to a viral infection. So I'm thinking about either a systemic fungal or bacterial infection.
Yeah, thank you so much for, I love how you bring out the things that are important to you, like the bone marrow suppression and the pulmonary infiltrates. Nabila, I can't wait to hear more.
Okay, so next up, the blood cultures that we got. So we got 1 blood culture from the central line and 2 peripherals. The culture from the central line revealed gram-positive bacilli, and this is again towards the beginning of admission. There was no growth on the peripheral blood cultures at 48 hours. Patient continued to have fevers 3 days into the admission, and we repeated blood cultures. At this point, she's on many antibiotics and antimicrobials. With ID's help, she's on vancomycin, Flagyl, micafungin, and azithromycin was added as well for atypicals. I don't have a whole lot of other labs. She has iron deficiency with an iron level of 13, percent SAT of 6, and a ferritin of 533, so kind of a mixed iron deficiency and anemia of chronic disease picture. In terms of the rest of our infectious workup, the full respiratory panel, respiratory culture, AFB culture, mycoplasma antibody, adenovirus, PCR, urine histo, Legionella, serum cryptococcal, galactomannan, beta-D-glucan, HIV, hepatitis, all negative. We did go ahead, even while all the cultures are pending and we don't have final results, we got a TTE that did not show any vegetations. And we also got a TEE, although that may have been slightly after, and that was negative as well.
Interesting. And you now have been watching her in hospital for 3 days. What are her counts doing?
Yeah, she is still pancytopenic, stable. She's required 2 or 3 units of red blood cells. Platelets are like in the 50s, and white count remains like 2.5 to 3.
Got it. And then just for me to clarify, did she get any respiratory culture sent?
Yes, she got respiratory culture sent. That was all, again, negative. Or yes, basically it was, contaminated or with just oral flora.
Got it. Interesting. Well, let me take a step back and ask one other question, which I probably should have asked before. Does she have any risk factors for TB at all?
No, she doesn't have the classic risk factors for TB in terms of she has, never been homeless or incarcerated, no IV drug use, no multiple sex partners, nothing like that.
Great. So that was just ticking something off my list. I guess the way that I would think about this is that we have a so far culture negative, except for gram-positive bacilli. So we have gram-positive bacilli from the central line. So taking a step back for that, yes, those could be key to what's going on, or they could be a red herring. Have they been ID'd yet in this story?
They do become ID'd.
Oh, they do, but we're not going to find out. Okay, fantastic. So gram-positive bacilli, I'm thinking about a couple of different things. So gram-positive bacilli are always a little bit of a curveball because they can be such harmless things like Corynebacterium, or they can be something as deadly as anthrax, which is not something that I'm invoking right here and right now. In terms of thinking about it, I think about, let me sit on that one while I go through the rest of her stuff. It becomes the point where I'm starting to wonder if she needs a way of sampling some tissue that is affected, which we have not yet done, which might include a BAL to get a lower respiratory specimen and find out what's going on in there. And I would want to talk to my pulmonology friends and see if they would send bacterial, fungal, and AFB cultures, as well as I might use a broad range PCR as well. And then I would also do a couple of other things. I would repeat blood cultures to make sure that she is clearing. And if not, I would be more worried that we're not appropriately treating this rod. And then were I at home, I might send markers for endemic fungi. That would be a first step. I suspect that the ID of the gram-positive rod is going to be key.
Yeah, and I wanted to ask, does the negative galactomannan and beta-D-glucan and the urine histoplasma, how does that change your thought in regards to endemic fungi? Because you mentioned that this could still be on the differential, or does that make them less likely?
Less likely, but I don't tend to think of them as either very sensitive or very specific. And notably, in some cases of disseminated fungal infections, I doubt that this is mucor, or at least I sincerely hope it is not. The imaging is wrong and the patient is wrong, but neither of them will necessarily be positive in mucormycosis. In general, I consider them to be tests that don't change my pretest probability very much in either direction. Then in terms of, let me circle back real quick to the gram-positive rod, if that's okay, and I really want to dial in on that. So breaking down like the gram-positive rods, I'm thinking about, did you say if it was aerobic or anaerobic?
I did not, and I'm not 100% sure.
That's fine,
to be honest.
But things that I'm thinking about, we could have bacillus, and you mentioned that she'd actually been bacteremic with bacillus before. We have the Clostridium bugs. We have Corynebacterium, which can often be a normal skin bug, and so we often think about potentially as a contaminant, although some of them can be nasty. We think about Listeria. Could this be Listeriosis? I would have trouble tying this all together with Listeria, but I will think about that. And then we have like our Erysipelas rhizopae, the Rhodococcus, which is not a coccus. And then, of course, we have the gram-positive branching filamentous, which can sometimes be called rods as a sort of off-putting. And I think about nocardiosis, I think about actinomycetes. This is not a good story for actino, which tends to present as sort of large, slow-growing growths in some area that's either close to the mouth or in the chest or in sort of the vaginal area in women. But I think that this could be potentially a story of disseminated nocardiosis. If in fact it was not a rod so much as a filamentous bug.
Yeah, thank you. Nabila, what did your team think? Were you also leaning towards like getting tissue, or what did your team do?
Yeah, for sure. We were also leaning towards getting a BAL bronchoscopy, which we did eventually end up doing. But the results of our blood cultures pointed us even more towards that direction. So I will talk about that. But just going back to the pancytopenia real quick, before we found out because the speciation wasn't until about over 72 hours into the hospitalization. We did consult hematology regarding the pancytopenia because both from ID and our perspective, there was concern, is there two processes going on or is it kind of unified? And would like a bone marrow biopsy be pursued in this case? So hematology was consulted. They suspected that all of this was kind of secondary to sepsis and not a primary hematologic condition. So that was not pursued. Our hemoglobin did respond to multiple RBCs, eventually over a week rising. Platelets also slowly increased over a week, but white count remained like 2.5 to 3.5. And then going to our blood cultures. So the initial peripheral blood cultures that were negative at 48 hours just after 72 hours, they showed gram-positive bacilli that were beaded and branching.
Oh, wonderful.
And they did speciate to Nocardia. So her antibiotics were changed. The Vanc, micafungin, and Flagyl were discontinued, and she was started on IV Bactrim and linezolid. And then there is like some more to the story, but for now, the workup that we did for disseminated disease included an MRI brain and also a BAL that we can talk about.
Natasha, you called it in the aliquot before. You knew what the misdiagnosis of the bacilli would eventually be, which is amazing. I wanted to ask you, how would you reflect on this? And do you think the fact that she was not on and did not have any significant oxygen requirement, does that tell you that this could have been more subacute, or does this not affect how you think about the tempo?
Oh, so taking the first question, the second question first. A picture of abnormal chest imaging and somewhat abnormal pulmonary exam, but with no stated pulmonary symptoms. What that really does is to push me a long way away from a typical bacterial pneumonia, and to a degree from a typical viral pneumonia. If you think about your patients who you've seen with community-acquired bacterial CAP or viral associated pneumonia, they tend to have pulmonary symptoms and to present with them. So this sort of gives me, all it does is give me a little feeling that I should be looking either at things that present super subacutely, like funguses, like eukaryotic pathogens, or something that has gone from the blood to the lungs, this is not a bad story for a thing that is lungs to blood or blood to lungs. No, and then your other question was sort of nocardia and reflecting on sort of how this might present. Nocardiosis is a famously difficult sort of diagnosis and syndrome to make. It's a bug that affects people who are immunocompromised, which I would consider her to some degree, largely because of her TPN and her and her vitamin deficiencies, which you mentioned in the first aliquot. But it's also a bug that can affect multiple systems. So it's a bug that affects the lungs. It definitely affects the brain, which is why she got an MRI. That's standard of care for disseminated nocardiosis, and affects your choice of antibacterial. And nocardiosis also fits into my goes to all the places bucket. So it can affect the bone marrow, which is something that you see more often with viruses and fungi than you would with a typical bacterial organism. It also goes into my bucket of bugs that are not covered by most standard antibiotics. So a good example of bugs like that include Nocardia. Actinomyces is the thing that gets brought up with it, but actino is actually delightfully sensitive. You can just treat it with penicillin. Nocardia, I tend to like Bactrim. And if you're dealing with brain, you often pull in something like imipenem. So yeah, I would say that it goes into my differential as a thing that is hard to diagnose, a thing that does a lot of things to different systems, and a thing that is relatively hard to treat.
Yeah, it's tough to hear it. Nabila, what did you end up doing and what happened afterwards?
Yeah. So this patient was started on Nocardia treatment 4 days into her hospitalization. Interestingly, on about day 10, the micro lab called us and said that a second organism was present on the initial cultures. It appeared to be a mycobacterial species that was preliminary identified as consistent with Mycobacterium fortuitum, that I'm not very good at pronouncing. And then that final speciation took about a month, but they were able to give us that initial data. The antibiotics were not changed at that point because it was suspected to be sensitive, even though we, did not get the sensitivities back for a while. She underwent a bronchoscopy with BAL. The cultures were all negative, though at that point she had been on antibiotic therapy. So that's the other thing to remember. This patient did really well. She was treated with IV Bactrim and linezolid. She was in the hospital for about a couple of weeks. She finished a 14-day course of those two, and then she was transitioned to Bactrim and imipenem with ID follow-up. And on the last ID note, it was a 3 to 6 month course that would be reevaluated at the time of outpatient follow-up. And then when I look back at the case, about 2 months after the initial blood cultures were collected, we finally had the speciation and sensitivities, which was Nocardia africana / nova and Mycobacterium fortuitum that was susceptible to the above agents that she went on. So she did really well.
I'm so glad.
Thank you for this. Yeah, thank you for
sorry.
this amazing case. How was it taking care of this patient?
Yeah, it was really cool because this was towards the end of my intern year. And so my seniors were starting to give me like more responsibility. And this patient came in like really close to rounds in the morning. We went and saw them. And I was like, oh, I think that's probably what toxic appearing means. And so like she, certainly did not look good. And even with everything going on, I think it was cool to see that like we were able to do all the proper steps and kind of like go through the ways that this could be disseminated. And then I think our consultants were amazing. The other thing that was kind of a cool takeaway is I think a part of this was because of the workup and a part because of how maybe young she was and didn't have like necessarily other risk factors that were outside of like the GI system. The fact that she bounced back so quickly, she looked miserable. And then once we started the right antibiotic therapy, it was like she was walking down the halls, getting herself food. And I was like, wow, that was cool to see. And our ID colleagues grabbed me that fantastic picture from the microscope, and that's the Nocardia. So that was cool to see.
Yeah. Natasha, thank you for the amazing discussion. If you were to tell the listeners about 2 to 3 teaching points they would take from this case, what do you think they would be?
Yeah, so let me first say, I'm so glad the patient did well, and it sounds as though you did an amazing job taking care of her, Nabila and team. And it's always just delightful to see a picture of the culprit in this kind of case. It's like, this is the bug that did it. So that's also very cool for me. Let's see, teaching points. I guess I think about immunocompromise in a much more subtle way now than I think I started out. I think I initially thought about immunocompromise as being a binary. Someone is immunocompromised or they are not immunocompromised. I now think about it in a much more nuanced way. I think about how someone's immune system might not respond in the same way as a totally healthy person. And that is a very, very different thing depending on the type of immunocompromise. So this patient was immunocompromised from the point of view of having a connection between her blood and the outside world and having nutritional deficiencies that affected her immunity. Other people who get nocardia, maybe patients who have had transplants, maybe patients with decompensated HIV. There are many reasons, but it's important to think about why someone is immunocompromised or not beyond the typical steroids, HIV, and so on. So that's my first thought, to think sort of broadly about immunocompromise. My second teaching point, I guess, would be that if you don't know what's going on, break it down by type of pathogen. So in this case, we thought about bacteria, we thought about fungi, we thought about viruses briefly, and we thought about mycobacteria, although I will say I did not call that positive culture. But in this case, she actually was at risk of both mycobacteria and atypical bacteria. I also think about bacteria as being kind of subdivided in my mind into the readily culturable typical bacteria and the often unculturable or difficult to ID atypical bacteria, like Nocardia, like a lot of zoonotics, like a lot of things that came up in our discussion, like Listeria. So I think if you don't know what's going on, that's always a good way to start, by breaking it down. And then I guess my third thought would be, that Nocardia is one of those bugs that is quite specifically challenging and that disseminates a great deal. So if you're dealing with a multi-system process, which I think everyone here correctly called that we were, that's something that was affecting at least the hepatosplenomegaly, at least the bloodstream, probably the lungs, and a question of the bloodstream and other organ systems as well, then you're thinking about bugs that can disseminate to that degree, which puts us in a particular bucket of some bacteria, some fungi, maybe some mycobacteria. And as a sidebar, I'm curious to know what would have happened if she'd had a bone marrow biopsy. But less so the viruses, less so your typical bacteria.
Yeah, thank you. And I loved how you broke down all of the systems and how you taught us how you think about the patient. You the only specialty that asks for more history after we present the physical exam is ID. So thank you very much. Thank you everyone for joining. I'm gonna pause the recording. If you have any questions or if you want to stay on and reflect, you're open to. So thank you all and have a wonderful day.